Hello everyone, and welcome to our webinar on analyzing cost and operations data to improve profitability and performance. My name is Greg Krantz and I will be the moderator for today's session. Over the next 45 minutes or so, you'll be introduced to Will Benish, who will discuss challenges in the healthcare industry related to cost and operations and the role analytics plays in providing key insights. At the end, we'll have about 10 or 15 minutes to address any questions you may have. If you do have a question, please type it in the Q&A panel. Be sure to ask the question to all panel members, and we will get to as many as we can at the end of the session. For those questions that we don't get to, we will be sure to reach out to you individually with an answer. I'd also like to mention that we will provide a PDF version of this presentation and a smart guide at the end of the session. Be on the watch for an email with links to the slides and the smart guide. Next slide. Now it is my pleasure to introduce our speaker, Will Benish, who is the Senior Product Manager for Cost and Operations at Medi Analytics. Next slide. Now let's review the agenda for today. So we're going to be covering a number of items. The first thing is challenges for providers in today's environment. We'll then be discussing the role of analytics in providing key insights to address those challenges. Will is then going to show analytics in action through a live demonstration. And then we will end with ways to ensure profitability and performance. And then at the very end, we will have questions and answers like I mentioned before. Now I'd like to turn things over to Will to get us started. Will?
Thanks, Greg. We're going to start right off and talk about some of the challenges that we're facing in today's marketplace. And even the title of this slide starts to get at some of the things that are happening in our world today. It says challenges for providers. What does that mean? I think even the definition of a provider is changing over time. Is it the hospital or the health system? Is it the physician group? Is it a ACO? The distinction between a provider and a payer is getting blurred. So there's a lot going on. We didn't want to fill this slide with all the different small challenges that are happening, small or large challenges, but we kind of summarized it in these three buckets. On the one hand, we have rising healthcare costs. We're still dealing with the legacy of a system and habits built around fee-for-service model. And there is a bumpy kind of fits and starts transition to value-based care that are all impacting profitability and ultimately strategy for health systems and providers today. We're going to go through each of these and kind of give some detail on them. As a result, kind of thinking about all these things, these are the new challenges, but the old challenges that we've kind of always had with us persist. So that is considering a health system as a matrix organization, that there are kind of pillars of operational performance, your imaging, lab, operating room, emergency room, and then kind of a clinical view that goes at a different angle across those, cardiology, orthopedics, OBGYN. It's hard to get all of these disparate groups looking and moving all in the same direction in harness. We also have challenges with physician alignment and engagement. So we've seen a lot of consolidation of more and more health systems employing physicians, but getting the physicians on the same page with management and really trusting and bought into the strategy has always been hard, and it continues to be hard in this environment. And last, change is hard, particularly for large, complex organizations like the hospitals and health systems of today, with a lot of habits and practices that have been entrenched. A lot of infrastructure has been built, and it can be hard to turn such a large and unwieldy ship. So let's think about some of these challenges that we're facing. Rising healthcare costs, labor costs and pharmaceutical costs are inputs that continue to rise. On the other side, revenue growth is getting significant pushback with declining reimbursement from private payers and government payers. This is something that started back in the 80s when they started the DRG models to limit the what Medicare would pay for patient care. That's been a model adopted by private payers, but it continues today with a number of shared risk models, bundled payments. All are efforts to cap the revenue that a provider can get and keep the provider accountable for reducing costs on their side. We also see that as a result of this, some of the old levers or old options available, strategic options to improve profitability, are less and less effective. So a decade ago, we may be deciding, should we invest in this MRI machine? We know we can get a lot of use out of that, and that will drive our revenues up to help us cover our costs. Modern payment models don't increase reimbursement for more tests or treatments. So some of those old techniques of fighting for strategic advantage are no longer going to apply. Those same old, I call them levers, actions that a manager can take to drive performance, left challenging legacy as part of the fee-for-service history. So in the past, rewarding more activity led to a lot of standards and habits among the care providers. It encouraged excess growth, excess tests and procedures. And as a result, we ended up with physicians performing care kind of their way, the way that they've always done it, a large variation in choices of when do we do this procedure, inpatient versus outpatient, this implant versus that implant, this technique versus that technique. The result of all of this is a lot of extra cost and extra waste as the hospital has to try to service all of these custom approaches. We also saw that despite these very highly customized approaches by different physicians, patient outcomes were not necessarily improving. High-cost patients did not necessarily have better outcomes than other patients with a much lower cost implant or procedure. And lastly, the challenge of the transition to value-based care. We see new types of contracts that are forcing challenging strategic decisions. So again, thinking about that old investment decision, should we or should we not invest in a new MRI machine? The new investment decision is, should we or should we not accept a bundled payment model from Blue Cross Blue Shield for knee replacements? And the inputs that are needed in order to correctly decide that strategic question are a lot more complicated than they were deciding should we or should we not buy an MRI machine. We still care about the market. We definitely still care about volume. But now our ability to succeed in these new contracts involves how well are we doing on quality? How much do we think we can improve on quality if there's an incentive in the contract to do that? How much excess waste do we think we can cut in terms of cost in a bundled payment solution that would help us be successful? If we're already running very efficiently, there may not be as much upside for us to enter into a bundled payment contract. The net takeaway is that for any of these new value-based care models, the inputs needed by these strategic decision makers have multiplied, and they're dealing with much more complex systems. The net result of these challenges, and this is kind of a simple slide, but it's necessary to say, is that profitability is dropping. It's hard to navigate these changing waters. Not everyone is doing it well. We have a legacy system built around volume, that's having a hard time adjusting to some of the new constraints. So, according to one stat that we found, the median operating cash flow is declining significantly. The operating margin, that's a pretty significant drop. And this is the median. So some hospitals are underwater looking for a way to turn things around. So as we're looking at these challenges, we internally got our industry experts together and we tried to say, what is healthcare going to look like in 5 years? Let's place our bets. And it was very hard to be specific. Are bundled payments going to be the way of the future? Is the Affordable Care Act and exchanges for health plans going to be the way of the future? Is that going to change dramatically, or is that going to be something that we can bank on? And our conclusion was, we don't know exactly what the healthcare landscape will look like in 5 years. We don't know what the market will look like. We see some of these broad-based trends, but it's hard to say universally across the board, this is what you knew, do these 5 steps, and you will be successful. Instead, there are some things that we do know, regardless of which specific contract wins out or what government regulation comes down the pike. First, we know that delivering high-quality, low-cost, patient-centered care will translate to success in any model. This is true under fee-for-service. It's true under ACOs, bundled payments, true under shared risk or integrated delivery networks. High-quality, low-cost, patient-centered care is and always will be the goal of healthcare. Second, accurate and timely data is a requirement to adapt to changing market characteristics and assess any new proposed payment model. We need to make data-driven decisions, and we need to have accurate, trusted, time-appropriate data in order to make those decisions. And the third point, which I alluded to earlier, successful product and enterprise strategy is going to require a comprehensive understanding of improvements across a range of related inputs and outcomes. This means quality, cost, patient satisfaction, revenue optimization, and compliance. All of these factors need to be weighed in context when we're considering a particular contract, and they need to be weighed for that particular set of patient volume or patients that we're thinking about. How can we improve our care for them? So we need to be able to build this broad portfolio of understanding for any group of patients that we're trying to take care of. Last, even if we have the right plan, right understanding of our market, of our inputs and outputs and where we can win, executing on that plan is going to require the trust and buy-in of the physician and clinical decision makers across the organization. We believe that that trust and buy-in requires transparent, accessible, and drillable analytics, which can equip the leadership and the analysts who came up with this great strategy to engage the clinical and operational team members and say, here is what is happening, here is where we see problems, let's work together to understand and make sure that we're all on the same page. That means being able to address the question or the statement, my patients are different, or our situation is unique. The answer is yes, your patients are different, your situation is unique. We need to be able to show you that even in your unique situation, this problem persists, and here is a path towards better quality, lower cost, patient-centered care for the patients that you're taking care of. I should add at this time, if you have questions that come up while I'm going through this presentation, feel free to add them in the Q&A panel, and I'll do my best to kind of glance over at that list, and if I see one that I can fit into the flow, I would love to address it. I think this can be a bit of a conversation between us. All right. All of these 4 things that we know about the future of healthcare have guided us in our strategy to give a solution that will help a provider be successful no matter what that market is. We think the key components are, I'm going to go back here, accurate and timely data, comprehensive data across a range of related inputs, and transparent, accessible, drillable analytics that can actually engage the decision makers whose behavior will ultimately drive success or failure of strategy. We've built our solutions around this. We've been working on this for years to create an enterprise offering for our providers that shows all of this information in context, that breaks down the barriers between siloed departments, operational departments across the enterprise, and then siloed clinical institutes, departments, divisions, however you organize your business. And we've built our product suite to match. Each of these areas has in-depth analytics, the correct KPIs, dashboards, guided analytics to uncover the problem, and are also integrated into one solution so we can get that longitudinal view of a service line across the board. Many of you are already familiar with at least one of our solutions. 20 years ago, MediAnalytics got our start in revenue cycle management, and we've built out from there. But we needed to fill in the gaps in that suite to make sure that we're telling the complete story. Are we covering quality? Are we covering patient satisfaction? How about on the cost side? Do we have the appropriate insights to bring all these disparate decision makers together and aligning them around a common vision and a common strategy, a common plan of execution? So we see here all around the analytics, VP of revenue cycle, quality, finance, documentation, supply chain, analysts, population health-oriented users and care managers, and then the chief medical officer, and of course their service line leads and the physicians themselves. I said that we've been investing in this for years. This is kind of it's a little bit in the weeds, but this is a view of our platform capabilities that we've built. One solution, bringing all the data into a shared place with the common functionality. So our platform has guided analysis, machine learning, predictive analytics capabilities, alerting, subscription reports, everything you would expect from a modern BI platform. And then focused analytics with the business value baked in each of these different areas: revenue cycle management, cost and operations, value-based performance, care operations, and kind of another product which sits across the entire platform, enterprise performance management, where we can take problems and opportunities identified through analytics and see them through to completion with integrated project planning and status. This is all part of our philosophy, which was summed up by the great management consultant Peter Drucker. He said, if you can't measure it, you can't manage it. And in today's world, we need to manage all of these different inputs and set our strategy based on all these different inputs. Therefore, all of these pieces are an important part of your enterprise analytics solution, and getting them to work in context with each other so we can see the trade-offs between cost and quality, the impact of one service line's increased volume on the operating room utilization and availability for other strategic projects. And that drives another Peter Drucker quote that I wanted to bring up. He said, management is doing things right, leadership is doing the right things. Each of these different areas we talk about are being managed independently, but only through doing a comprehensive summary, can we make sure that we're doing the right things? Are we engaging in the right strategy for our market, strategy for our contracts, entering into new value-based care arrangements? In order to assess if that's right for you, we need to have a comprehensive understanding of how your business works. Today, I want to drive in particular into the cost and operations side. I think it's foundational to making and setting your enterprise strategy and your strategy service line by service line. So this is a new product suite that Medi is adding this year. We went live just a couple months ago into our portfolio. So understanding that this is part of that larger enterprise analytics umbrella, the focus is driving true behavior change and executing on an enterprise strategy. And I want to kind of go through each of these different product areas in turn. While we go through each of them, and we'll start with a service line, our approach is to consider who are the strategic leaders that need to interact with this data, and what are the success factors and critical components that they need to manage in order to become successful. Along with that, or to say that another way, what are the key levers available for these leaders in order to move the needle and actually make a difference? What are the key things we need to analyze that will really make a difference between profit and loss, success and keeping things the way they are, which is the failure of a strategy to make a difference. And on the flip side, or in order to actually see results, we also need to consider for each of these products, who are the ultimate decision makers or operators whose buy-in and behavior change is required in order to enact a strategy. And how can we make sure that we're earning their trust and buy-in and belief in these same numbers? If we're setting our strategy based on this analysis, how can we make sure that at the same time we're showing the right view of the data and the right insight to get those physician leaders, nurse leaders, supply chain leaders all on board with that one shared vision? So that's our focus. And I'm going to go through kind of each of these products, and then I'll give a quick demo of how they look all in context in our platform. We're going to start with service line, which is kind of the umbrella for assessing the overall health of any particular service line, product line, or particular procedure or MSDRG. We're going to analyze volume, variation in practice patterns between physicians, tests they order, length of stay, things like that. We're going to look at your margins and profitability as well as their change over time or change between different payers or markets. And then we're going to break down that cost and figure out what are the cost outliers and what are the big drivers of cost. Where is there opportunity to reduce our costs for this particular set of patients? This analysis is going to inform decisions around strategic planning and investment. Where do we go in the market? What physician groups do we partner with, or what large employers do we partner with? Care standardization, new contracts and partnerships, all of which result in what we're looking for: sustained profitability, lower cost, strategic growth, doing the right thing, and better outcomes, engaged and accountable physicians. As part of service line, as we drill into what are those major cost drivers, we want to make sure that we give insight to each service line on their major sources of cost. A huge part of that is in supplies. 25% approximately of a hospital's costs come from their supplies, and a big part of that happens in the operating room. So we pull your operating room data and physician preference cards, look at supply costs per case, variation across physicians, and wasted supplies to help inform decisions and meaningful conversations around care standardization, physician preference items, ordering patterns, all of which result in lower costs, better outcomes, engaged physicians who are bought in and understand and can kind of believe that, yes, this implant has the same readmit rate, the same infection rate, as the alternative that I've been using, but it comes in at half the cost. Maybe I should switch. We also want to understand the labor side of this equation. Labor is half of the cost of a hospital. And that comes down to nursing and techs. Major drivers here, levers for improvement, are managing overtime and contract labor, getting your staffing right. You're matching your staffing with your units of service, your patient days with how many nurses are on the floor, getting the skill mix right. Could you be using nurses aides or LPNs instead of full-fledged RNs? Watching your changes in wages over time and making sure that you're managing that appropriately, and then filling vacancies and making sure that you aren't hiring for positions that aren't needed and that you are hiring for those desperately needed positions where they matter. All of this analysis informs decisions around scheduling, staffing levels, skill mix, as well as budgeting and planning. And it results in less costly overtime, lower cost per case, improved employee satisfaction, and then better patient outcomes when we hit that right staffing mix. This is important as a standalone silo. This is an important tool for nurse managers and the chief nursing officer to manage her business. It's also important for a service line leader, maybe the chair of cardiology, for example, to understand how the nursing units that she's responsible for sending her patients to, the kind of cardiology units, that's a big driver of cardiology's overall profitability. It matters, and we need to start sharing this information across the board and looking at it in context. We also need to understand a couple key resources at a hospital that have a major impact on volumes and therefore profitability. That's the emergency room and the operating room. For the emergency room, we pull in emergency room visit data and we look at changes in volume and patient mix. Look out in the region, where are patients coming from, where are they not coming from? What about patient flow through the emergency room, from arrival to triage, triage to in bed or seeing the doctor? Where are the big delays? What tests or orders or treatments are causing holdups? All of these holdups result in longer wait time, which is a huge patient satisfaction impact, even on patients who are eventually admitted into the hospital. We see patients who had a negative emergency room experience giving much worse reviews for care throughout their stay. But it's also an important source of volume. If you get a reputation for having long wait times, or patients are leaving against medical advice or without treatment, emergency rooms are over 30% of the volume of a typical hospital. We can't afford to let that volume go. It's not good for the patient. It's not good for us. So this information helps us appropriately staff, standardize care in the emergency room, particularly for stroke patients or STEMI patients. And then how can we align those support services who are trying to manage a number of customers across the hospital to make sure that they're prioritizing or appropriately staffed to handle the volume and kind of trends of when the need from the emergency room is highest, imaging, lab, radiology, or consults. All of this results in higher volumes to the ED, higher admissions to the hospital, lower cost per case if we're spending less time and doing less services per patient, treating them more efficiently, improved patient outcomes, and high patient satisfaction. A similar kind of bottleneck or constrained resource that we need to optimize is the operating room. If we want to strategically invest in knee replacements, do we have the capacity to increase how many procedures we're doing in our OR? To do that, we want to look at our scheduling accuracy, our room turnover time, room and block utilization. If we give a surgical block to a surgeon who's not using it fully, that's very high opportunity cost in terms of the other procedures which could have been done during that otherwise dead time. Let's look at the operation metrics like on-time starts, delays, last-minute cancellations. Let's also look at the patient flow, look at variation in procedure length between doctors. Can we point out best practice and kind of support meaningful conversations around how long is the appropriate amount of time to schedule it, how long should it take, what's going on that's causing systemically longer cases for this surgeon versus this surgeon. PACU utilization, analysis by the anesthesiologist and the type of drug used on how long they ended up staying in the PACU. If that PACU is full and we have to put the operating room on hold, again, incredibly costly in terms of our opportunity cost of procedures that we're not getting done, really hurts physician satisfaction, and it's bad for patients who are ready to go and then have to get stopped. All of this informs decisions around scheduling practices, standardizing care, allocation of surgical blocks in the schedule, improving pre-admit or pre-anesthesia screens. All of this results in higher utilization, which means lower cost per case. We're spreading that operating room cost over more cases. Definitely higher volumes, which means higher revenue and profitability, fewer delays and cancellations, better patient outcomes. It's good for the patient, higher surgeon satisfaction, more predictability, higher volume for the surgeon. That's a win all around. Seeing all this information in context helps the surgeon make their case, where sometimes before, if it was just about cost or just about quality, it's hard to articulate how some of these decisions made to improve costs can have unintended ripple-down consequences in all these other areas. Bringing all this information to the table in context lets us have a much more meaningful and impactful conversation. And then lastly, kind of revisiting supplies, but from a supply purchasing perspective, can we compare the different departments and look at our supply spend versus budget? Can we look at our ordering practices and see, are we using the rates that being a member of our GPO has enabled to us, or are we still going with our preferred private relationship for this particular implant because the guy took me out for steaks last night? Let's look at vendor overcharging, where they're charging us a different price than we expected based on our price list or our GPO price. And then let's share this information. Let's make sure that the head of cardiology can see, hey, this is what my nursing units are costing from a supply point of view. This is what the cath lab is spending on supplies. Here's a particular supply that I've been buying a lot of that suddenly the price has tripled. That visibility across the board can have meaningful impact on the decision making, where just looking at a high level number of saying our supply cost of the hospital is going up, it's hard to deal with that in a strategic way and know what that really means. So here's a couple, well, before I do the key takeaways, let me actually switch over and show what this might look like. So this is in our demo site with demo data, so don't get too concerned if the numbers don't look realistic to you. But all of these solutions are live, and they're in context here. So we can see our service line overview. Looking at cardiology, we can trend our admissions or trend our outpatient visits over time, year-to-year comparison, look by DRG. We can see our kind of an income statement, net revenue, contribution margin, and then profit, net income. We can also look at that per case. So we can look at our net income per case over time for this service line, or potentially for a particular DRG. Just filter on that DRG, and now we see it updating all these numbers. Now we're just looking at that DRG across the board. Here's my income statement, my volume changes over time, year over year. significant growth in this DRG, that's great. We can look at our performance within our region. So here's kind of our market view. Again, this is our development data, so it's a very clean block of zip codes. We can also look at the change over time. Where are we growing? Where are we shrinking? Perhaps a competitor is stealing our volume for this particular service line or particular DRG. Let's look at what's happening in the emergency room. Our visits, admits, patient flow performance, our particular metrics around myocardial infarction. Let's look at our census for the kind of cardiology visits in the ED last week compared to year to date. By time of day, are there particular surges that we need to be accounting for in terms of our ability to staff the ED and also the support services and the cath lab that are all needed to make sure that we're treating those patients well? Look at any of these metrics here by, here's arrival to triage by time of day, for example. Arrival to triage over time. Are we improving? We started an initiative for it. Has it made a difference? Does the performance look different if we only look for a particular complaint or a particular acuity or arrival method? All of these are dimensions available within the analytics. Switching over to the operating room. Let's look at our case volume over time, year-to-date changes, percent cases on time, or percent first case on time start, wheels in to wheels out, cut to close, room and block utilization. How are we doing on our block utilization? Is it different for this OR or that OR? Or is it different for this surgeon than this surgeon? All of these views are drillable, so we can just view report or edit the report, and this will drill into our robust analytics capability, and we can slice and dice and look by physician or by anesthesiologist or by operating room, whatever the appropriate view is that we need for our analysis. We can look at our labor costs, filtering on just the cardiology's nursing units here, or departments actually. So we have the cath lab, a regular nursing floor, and then cardiology, a non-invasive unit here. Look at our productivity percentage, our labor expense per period, some higher level analytics identifying where there might be opportunity for improvement, where we have some excess FTEs staffed on one of these departments. We can break out our overtime dollars and contract dollars, compare our worked FTE to our target worked FTE. This is what we've earned for that year. This is why we're over 100% profitable or productive, because we're using fewer worked FTEs than we've earned, and we can look at the year-over-year variance, or the year-over-year variance, and also the year-to-date versus target variance. We can trend our productivity, and we can also get a glimpse of how our skill mix is changing current period versus year-to-date. So slightly fewer nurses, slightly more support staff. That may reflect an initiative that we've been doing to try to make our skill mix more profitable and more appropriate. And then lastly, just looking at a couple of those accounting units, trending our total invoice spend, maybe by vendor or by accounting unit. Say, hey, who is a particular vendor? I can apply this as a filter, and I can see how that vendor is trending over time. All right, that's a quick demo. I'm going to switch back to the slides, and we'll just cover a couple high-level takeaways. The first point is that point we made earlier. What do we know about the next 5 years? The only thing that we can predict is that unpredictability and changes are here to stay. And in order to effectively make sure that we're going to weather that storm, that our strategy is going to be responsive to our market and our business characteristics, data and analytics are going to be a critical aid to set and execute that successful strategy. Execution is going to require aligning decision makers, and earning buy-in is going to require a comprehensive approach where you don't look at things in a vacuum, but recognize that this is a very complex operation where all the parts impact each other. There are always trade-offs that we have to fully consider and unintended consequences that we need to measure and monitor to make sure that an action in one area isn't resulting in something else going the wrong way. Last, and kind of most basically, lowering costs and improving efficiency is the cornerstone supporting every successful strategy. All right. Are there any questions? I'd like to say, yeah, thanks a lot for listening in. I appreciate your time. Hopefully this sparks some kind of ideas or questions in your minds. Do we see any questions about the solution or what we talked about today?
And remember, if you have questions, please type them into the Q&A panel, and be sure to send to all panel members.
All right, so one question is, can we augment the analytic solutions to add new or non-covered benchmarks or data sources? The answer is yes. An important part of our platform has been recognizing that while we are exploring what we believe are the most important levers and drivers of success, every hospital or health system is unique. Every challenge may be unique, and in order for us to fulfill that promise of a comprehensive view and to be able to gain the decision makers' trust, we needed to allow additional data to round out that story. So we've built a product offering called MediCreate that lets you augment the existing solutions with additional fields, dimensions, even metrics based on data that you provide that you can then see in context along with the rest of the solution. There's one other question, looks like. What would it take to implement these products if you already have an existing solution? Two-part answer. The first is that we would require the new data sets, but if you have a solution, you already have, the platform is set up, you're set up as a client, so just sending us the new feeds would allow us to turn on the new data sets. And we can get into this if you are interested in following up on any particular solution on what the required data set is. But it's very easy to set up, and these are standard products in our SaaS solution, so it doesn't require any new hardware costs or investment of that sort. I did also want to add that the service line economics view, we have a core version of that which we can stand up using existing revenue cycle, or we call it BOSS, Business Office Suite data, which is the patient accounting data, or the revenue integrity claims data and claim lines, and that will show us some of the dashboards that I showed highlighting changes in volume and patient mix, switching from inpatient to outpatient, payer mix, and it also highlights physician variation in terms of the different services and orders that were put in for different patients. That shows up in the charge data and the claim lines data. We have a lot of analysis that guides you through highlighting this is meaningful variation between doctors that has probably the largest impact on the cost bottom line. This particular MSDRG, we see that there's a lot of variation, and standardization could have a dramatic impact on the cost side. So just that one solution doesn't require any additional feeds beyond what you're already sending for Business Office or Revenue Integrity. All right, Greg, I don't see any other questions.
Okay. All right, well, no, I don't see any, But
okay.
I just want to thank everyone for their questions, and thank you, Will, for providing your insights. If you do have any other questions about the information discussed today, please feel free to reach out to your Medi Analytics account representative. We will also be sending out a PDF version of the webinar slides today, so look out for an email soon. We will also, as promised, be providing a smart guide, a cost and operations smart guide. So those that attended the webinar will receive that. And this brings us to the end of our session. So thank you, everyone, for joining us today, and have a great day. Thank you.